I also want to just say thank you so incredibly to Dr. Paul Moyedi and Dr. Armstrong and Denise and Shayna for being here today, because the evidence that they're going to be advising you of today and their patient stories and how people are impacted by the decisions that policymakers make is really important for all of us to be here and hear, and then really advocate for each of us on everyone's behalf. So I wanted to just say that this whole advocacy initiative was born in 2015. We knew that we had gone out with a no forced medical switch policy because we didn't have very much information, and we knew that we did not want governments to make decisions for us. And then fast forward a few years later, we're finding out now that governments are now mandating forced switches, switching patients from biologics to biosimilars. We've been in conversations with governments over the last 3 years, and we have been advocating on your behalf. And then suddenly we found out in May of this year that BC has decided unilaterally to make a decision to switch patients from their biologic to a biosimilar. Patients didn't have very much information. Gastroenterologists didn't have very much information. And by the way, I'm going to change gastroenterologists to GIs. GIs didn't have much information. And patient organizations, we weren't consulted about this move that BC did. And they kept saying to us, and they actually wanted everyone that they engaged with to sign a non-disclosure agreement, an NDA. And we refused to do that because we knew that by doing that, we would not be able to advocate on your behalf. So then we decided that in the summer, this summer, that once they did the switch, BC did the switch, we needed to put together an evidence-based decision-making that they should have in front of them. So we went out to all of you. And we had 1,000 patients who responded to our survey and told us how they felt about this non-medical switch policy. Many of you overwhelmingly were vehemently opposed to this non-medical switch mandated by governments and not patient-doctor choice. Then we went and also did a survey of our GIs. They also overwhelmingly said that their switch is not in the best interest of patients. Then we also talked to nurses who deal with patients day in, day out, and they agreed on that notion as well. So we've continued having these conversations with the BC government, and the BC government is not hearing us. And most recently, we have now found out that Alberta is going to be making this switch for Albertan patients this upcoming week. They've not consulted with patients, not consulted with our GIs, not consulted with nurses, and not consulted with the patient organizations that represent your voice. So what we wanted to do is to make it very clear to governments across Canada that the decision to switch from a biologic to a biosimilar remains with patients and their doctors. It is your choice. It is not a choice that government should be making. So now what we're finding is that governments and private payers are willfully disregarding our findings in order to achieve questionable savings and to increase the use of biosimilars generally. We've heard that the biologic makers are willing to have discussions with governments to decrease their prices and take away those questionable savings. So if that's the case, why are you as patients, why are your loved ones being forced to switch from what you are doing well on and maybe go on something that is probably effective and safe, but there are a lot of things that could change there that can make sure that you might not end up being stable. I'm sorry, it didn't come out as clearly, but that's Paul's job. He's going to come up here and talk more about that. So what I want to say is that we've been vigorously sharing our messages with governments through individual messages, meetings, media. We've gone out, we're on social media, and they're not paying attention. So we've also been working now, and when we talked about all this evidence, what we heard from some of our politicians is that surveys of patients, surveys of GIs, surveys of nurses are not evidence-based. And we're looking at that saying, this is the voice of our community telling you what's important to them. And when we were talking about this and advocating on your behalf, we actually joined forces with the Canadian Association of Gastroenterologists, and they too have concerns. Those physicians, GIs, have concerns about their patients being forced to switch onto a biosimilar without consultation between a doctor and a patient. We know that a doctor knows you individually. They talk to you about the medications that should be important to you and what your body needs. Why are governments making this decision? This is the question today. So now, Dr. Paul Moietti is actually going to come and talk to you about how CAG, the Canadian Association of Gastroenterologists, also don't support a non-medical switch. It's really time for us to ramp up our efforts. If we want to have impact, we need your voice, and we have to have it loud and really clear to governments to say, we don't support this. We're on our social media, we're on Twitter, Instagram, Facebook. Please support us, please share this message. If you don't want this to impact you and you don't want to be switched from your biologic to your biosimilar, please get your communities to join in and advocate. Because what we've heard from governments, what governments have come back and said to me is, the patients didn't really say very much in BC. You know, we switched everybody in BC and the patients didn't really say anything, so we're good. And now Alberta's come back and said, hey, we heard patients in BC didn't object. And I said, well, you know, you kind of surprised us with that announcement. Had we been given enough information, we're hearing our patients now, because as they go to their patient support programs or when they go see their gastroenterologist and they're telling them that you need to be switched, now they're angry because they didn't know about it before. And so we need your voices to be heard, because governments are saying patients didn't say very much. They're totally fine with this decision. So again, what I'm saying is that we will continue advocating on your behalf. We're going to continue meeting with policymakers, and we need you to join forces with us. On that note, I'd like to introduce Dr. Paul Moietti. I want to thank you so very much for being here today, because I know you're like catching a flight next to somewhere else, and you're a very sought out speaker, as well as Dr. David Armstrong. So thank you very much from our community for being here today.
Thanks, Mina. Now, can everyone hear me? Good. As Mina said, I'm Paul Moietti. I'm from McMaster University, and McMaster is famous for giving the world a thing called evidence-based medicine. The concept that the way we treat patients should be based on evidence. Seems pretty obvious, really, but actually that isn't how we used to practice in the past, and indeed we still don't. We still do what doctors think is a good idea, and sometimes what patients think is a good idea, but what doesn't necessarily work. And to begin with, the people at McMaster who put forward this theory were criticized. And then when people started doing the first randomized trials, these are trials where people are randomized to one treatment or another, and found that in one common practice in cardiology, they were basically killing people. And they'd actually killed more people than died in the Vietnam War through doing this particular strategy. And it made sense to cardiologists, but was actually wrong. And randomized trials showed us that. And they're really the best form of evidence and what we focus on in doctors if we can. So I was asked by Mina and all those at CCC and the Canadian Association of Gastroenterology to head a team to look at this in terms of evidence-based medicine. So we collected all the evidence that we could, particularly focusing on randomized trials, and that's what I'll talk about today. And they're not always easy to find. They're not always in the best journals, and you do have to struggle sometimes. Fortunately, I have a great team because we're also part of the Cochrane collaboration, which is a group that get this evidence together and synthesizes in a usable and rigorous way. So at this point, I would like to thank Kathy Yuan, who isn't here, who did all that searching, and for Grigoris Lontiadis, who also helped me with this work. But also David, who is an author on this position statement, and Ida Fernandez, who was part of CCC in the past, and also Eric Benchimol from Ottawa. So we as a group got together, and this is the first time that people have looked at the evidence rather than just saying what they think. And given now we accept that this is the right thing to do, it's quite surprising really that there have been groups all over the world that have said one thing or another about biosimilars, but no one's looked at the evidence. So this is what we have done, and the reason we've done it, if these drugs were identical, there's probably no need to do it. And for many drugs like your blood pressure medication, an antidepressant or what have you, they're just small molecules. You can create them in a test tube and make them identical. And if they're identical, they should work the same. But biosimilars aren't like that. They are more complex. We cannot just make them in a test tube. They are just too difficult to do that. So what we do is rely on nature. We put things into cells and let the cells make the biologic for us. And obviously many, many cells amplified over time. We get the infusion that many of you will receive. But the problem is there's that biologic element, there's that cell that you have to use to make your product. The problem is if another company does that, they can never make it the same. That's why it's called similar, not the same. Of course, they use the same sort of ideas as the parent company or the original company, but they can't use exactly the same cells. And indeed, the process is much more complex than your average drug. So they can never quite be the same. So the question is, are they as good? And you've really got to look at the evidence for that, which is what we did. So first of all, there are two scenarios. Mina concentrated on the non-medical switch. There is the case that you've been doing fine with, for example, your Crohn's disease for a few years, but then nothing like immunosuppressants or whatever you've tried is working, and is now you think it's right when you've discussed it with your doctor to start an anti-TNF such as infliximab. If you make that decision, there is one randomized trial in 220 patients which randomized people to either the biosimilar of infliximab or the original product. And at 6 weeks and then followed up for 30 weeks, they were roughly the same. Now, because these numbers are rather small for us as evidence-based researchers, we can't be sure that there may be a 15% difference between those drugs, which is really, we'd like more evidence before saying they are the same. But nevertheless, the evidence we have would suggest maybe it's okay to start a biosimilar rather than the originator if it's significantly cheaper. Yes, money is not everything, but basically the health service is very expensive. It's perfectly reasonable for governments to try and reduce costs as much as possible, as long as it's safe for patients. The problem is we can't be sure, but as I say, the best evidence, certainly we can't argue if you discuss it carefully with your patient that this is something you might want to do. We next look at switches. And these are people who are doing well on the example I've given, infliximab. So you take someone who's with inflammatory bowel disease, who's doing very well on infliximab, and you either keep them on the original product, or in a double-blind manner, so no one knows what the other's getting, you switch them to the biosimilar. So we have two randomized trials that look at that in 448 patients. And basically what they show is that those that are switched to a biosimilar have a roughly 33%, a third a greater chance of their disease worsening or needing to switch to another biologic. To us, that was significant, and it is not entirely implausible. Yes, they are similar, but they're not the same. So now you're introducing someone who's doing well on one product with a slightly different product, with a slightly different immune profile. It's not surprising that in the group that are doing well on infliximab, they might not do so well on this drug. So for us, I mean, this is significant. This isn't a small thing. And given how serious inflammatory bowel diseases are, this is not something we feel government should be playing around with, and our recommendation is not to do a non-medical switch. It's still low-quality evidence. Of course, you discuss with the patient. If the patient really wants it, go ahead when they know the evidence, but this should not be done as a routine basis, in our opinion, from the evidence. Thank you.
So thank you very much for the invitation to speak here, and it's a pleasure to follow on from Paul Moietti, who's done a sterling piece of work with the Crohn's Colitis Canada and with the Canadian Association of Gastroenterology in reviewing the literature and trying to provide us with evidence to support our clinical practice. I was asked if I wanted to speak about something, and my initial reaction was probably not. But as backstop, I thought one of the challenges with this is that high-level policy decisions or recommendations to government are worrying, they're scary. And what I wanted to maybe do is to talk a little bit about the, if you like, the coalface of how we deal with this, and what are the things that we need to deal with the threat or the challenge of switching between medications, and try and put that in the context of the sort of, I initially said the patient-doctor, but really the patient-healthcare provider relationship, and how that partnership needs to take control. And one of the challenges that we have is, and I really don't need to say this to you, I'm sure it's preaching to the converted, is that the inflammatory bowel diseases, ulcerative colitis and Crohn's disease, are complex diseases. They manifest in lots of different ways. They're chronically relapsing conditions, so there are times when one can feel well and times when one feels sick. The symptoms differ over time, so different people have different symptoms, and flares of disease can occur with different symptoms. And from a healthcare point of view, we have different ways of monitoring. We can ask you how you're feeling, we can do scopes, we can do investigations, we can do blood tests, we can do yucky stool tests. There are a whole slew of things that we can do to monitor. And when we try to do our best to keep disease under control, we're trying to monitor, you and healthcare providers are trying to monitor this and work out how best to manage. And we're doing that in the context of a lot of other things that affect our symptoms as well. So if someone with inflammatory bowel disease feels worse, it may be the inflammatory bowel disease that has flared, but there are a lot of other things that can affect that. Things like stress can produce symptoms that may be like inflammatory bowel disease or may indicate a flare, but they may be something else that needs to be managed differently. There may be dietary changes for the best will in the world to try and feel better, to improve the sort of the health-giving nature of the diet. Other conditions can interfere with this as well. So unfortunately, having inflammatory bowel disease does not preclude the afflictions that affect everybody else as well. It's no protection against gastroenteritis or tummy upsets or food poisoning or anything else. There may be changes related to medications, and some of those, as we've heard, may be related to biosimilars. There may be changes within class which we may choose or may be forced upon us, but they can also occur because of other medications for other conditions as well. And then things like travel and all of the other things that we want to do with our lives can also affect our symptoms. So trying to monitor this is really tough. And part of the reason for bringing this up is that managing the challenge of biosimilars or changes in treatment, and this is going to come up for other medications as we go forwards, is really a microcosm of managing inflammatory bowel disease overall, and in fact in managing other complex conditions. And so the changes that occur really need to be monitored, and it's a part of my plea, and that's not to people with inflammatory bowel disease, but actually to me and my fellow healthcare providers, whether nurses, dietitians, nurse practitioners. We need to have information that we can work with, because the initial symptoms need to be deconstructed. We need to understand what's going on to be able to help and to work in partnership. And the phrase that occurred to me is one I remember from reading many years ago from The Lord of the Rings, was that all that glitters is not gold. The symptoms that we get don't necessarily mean that the IBD is flaring up. It was interesting, actually, when I looked at it, actually the phrase, at least one of the early versions of the phrase, came from Shakespeare, from The Merchant of Venice, and his phrase there is actually, all that glisters is not gold. Not all that glitters is not gold. So glister is actually a biosimilar, or glitter it's a verbosimilar. It sort of means the same. But actually, if you say glister or glitter to somebody who's a Shakespearean scholar, he may well actually raise antibodies with him that he feels you should be saying glisters and not glitters. So the challenge for gastroenterology is that, if you like, all that's brown is not gastroenterology, or all that hurts is not IBD. And so to manage IBD, it's a complex undertaking that involves all of us who take part in trying to improve well-being for inflammatory bowel disease patients, and we need all of the relevant information. So that means, without trying to turn everybody into obsessive compulsive healthcare providers or patients, we need a clear understanding of what the symptoms are and some of the chronology, some of the timescales, some of the other symptoms that will help in managing disease. So I think, as I say, this is not to have major diaries or everything written down or videos of the last 3 years of your life, but it's actually to try and pick out and to understand and to work together to understand the key things that change. If somebody has worsening pain, what else happened around that time? Are there other things? Are there dietary changes, medication changes, other things that we need to discuss? And in a way, effective healthcare is really, it's a scientific study. It's actually studying on an individual basis what happened to you before you came into the office, before something changed, and how do I then understand it? So I guess my plea from this is really that better healthcare in the context of biosimilars, in the context of managing these complex diseases, is really based on a partnership between those caring for the patients with IBD and those with IBD, so that we can share our knowledge and we know what precisely we need to know to actually improve healthcare. And so we need to educate ourselves as healthcare providers to understand what we need to know from the people we're working with, from the patients with inflammatory bowel disease. But that partnership also means that we need to work with patients with inflammatory bowel disease so that they can understand what information they need to impart back to us. So that's my backstop, if you like, plea for a partnership going forwards. And I would like to say that today, really, I think, is an example of that sort of partnership between Crohn's Colitis Canada, between the Canadian Association of Gastroenterology, between all of the healthcare providers, and the work that you do advocating for and looking after people with inflammatory bowel disease, and coming together to try and deal with some of the challenges and potentially external challenges from funders and payers who have a job to do, but should not be allowed to use evidence more as support than illumination. There's a great phrase about somebody using statistics like a drunk uses a lamppost, more for support than illumination. And there's a danger sometimes that people use evidence, particularly payers, more for support than illumination. So with that, I'm going to hand back to Mina.
Thank you.
So I'm not as articulate as these lovely people. So I wrote something for you guys. It's kind of my perspective on what's going on. So my everyday is affected by Crohn's disease, but it's not because I suffer from it. It affects me because it stole my healthy child, and in her place, it gave me a warrior I didn't dream of. The trauma of having a sick child is nothing you would recognize unless you also have a sick child. Despite following a pediatrician's instructions for years, my daughter became so unwell that her grade 2 teacher suggested I drive her to the Children's Hospital in Edmonton. It was 2 hours away from our home. So I did. It felt like a miracle and devastation had hit me all at the same time. My tiny child was diagnosed with a chronic illness in 2014. The medication required to sustain her health can also cause or have heavy risks, so it's not a decision we make lightly. With her doctor's help, we decided on what was the best option for her, and it has been successful for almost 6 years now. But we've seen her through countless IVs, needles, and procedures. This battle has definitely taken a toll on our hearts as parents. So in 2018, my husband and I decided to move our family from Alberta to the north coast of BC. Being the region we both grew up in, it offered us a support system of extended family and good friends, and it has helped us cope more easily. Now we have been told that the BC government is asking us to switch our child to a similar medication that has not been tested on pediatric patients. Not because it's what's best for my child, but because it's what's best for their budget. My husband and I work tirelessly to provide a secure life for our family. So why am I being asked to let the government dictate potentially hazardous and dangerous medical choices for my child? That's all.
I just recently started to understand how serious my chronic illness is. I was only diagnosed when I was 7, so it wasn't that serious to me because it wasn't something I could see. It was just kind of a word to me. And now that I'm getting older and it's starting to affect me a bit more, it kind of just dawned on me that it's actually really serious. So switching to a medication that has only barely been tested on adults is actually really scary. I can only imagine how scared younger pediatric patients are. I believe that forcing families to switch to a new medication has zero benefits for them, and it's kind of selfish.
That was seriously well done. Thank you very much. So we're going to open up the floor to questions. Let me just tell you how this is going to go. So if you have a question, please come forward to the microphone so that we can record your question and then your answer. Let's try and keep the commentary to a minimum and really take advantage of our panelists for specific questions. Does anybody have a question to start off? Great. Please come forward.
Very much for that. I was just wondering how the government is addressing.
Just one sec.
Can you hear?
We're going to turn that on.
Okay. Thank you so much for that.
Not still, oh God, it's
There we
going
go.
on.
Okay.
Okay, I'm going to start a solo soon. Okay, thank you. I was just wondering how the government is addressing the evidence with respect to children versus adults on this issue.
So, we researched the evidence. There is one pediatric cohort study in just 36 patients. The challenge really is that obviously this tragic disease can occur at any age, but you were very unlucky. 7 is not a usual age to get this. And it's actually most common in your 20s. So if you look at the children with this disease, there are less of them. And of course, they all grow up carrying on with this disease. And so adults, we have a lot more people with it to study. So it is a challenge to get evidence in kids. They have done it for the original drugs. It's arguable whether they need to do that all over again for children specifically, but they should, if these drugs are being used in children, ideally they just shouldn't use them, in my view, because it's not, as I said, there's not so many children with this, so it's not that expensive for government. And if they're wanting to save money, they probably should focus on adults. That's just my opinion. But if they were to do this, they should try and get as much randomized trial evidence as possible and monitor people closely, which is what David was alluding to. So if you do these switch, you've got to see what you're doing and compare it with those that stay on the originator and see if there is any difference. And as far as I'm aware, no government in either Canada or anywhere else is actually doing that. And to me, that is concerning. I think it's the best word.
Hello. I'm over here. I'm seated because I have trouble standing. I just want to let you know I'm not at the mic. And I have more of a statement than a question, but after reading it, you'll see why it is supportive of what you're doing. And if anyone would like to comment, I would be very open to that. My name is Eileen Shushat. I have rheumatoid arthritis. My health is both complicated and fragile, as this disease affects every musculoskeletal system, every internal organ and muscle. And after 20 years and 7 failed biologics, many hospital stays and surgeries as a result, I'm finally on a biologic that works, and it is number 8. My health is a fine balance, so I'm going to ask governments to please not risk my health, my world, and my husband's world by doing something as arbitrary and unnecessary as allowing a government, not my doctor, but a bureaucrat, decide that a biosimilar medication would work for me, because we know it won't. And I really don't want to have to die or become paralyzed, both of which are possible in my world, both of which I've faced, and neither of which are an exaggeration. I don't want to have to do that to prove it to them. Thank you.
Thank you for that. Do any of our panelists have any comments?
You can't really add to that.
No.
No.
Fair enough.
If, Janet, if I can just add to the previous question around the governments and pediatric, it's interesting because we actually at Crohn's and Colitis Canada did talk to the BC government. We were invited to have discussions, and what we heard from the surveys from our patients, from our GIs, from our nursing community, is that they all had exemptions, that if this policy was going to go ahead, there should definitely be some exemptions. And the exemptions were for pediatric patients, the exemptions were for nursing patients, and the nursing as in mothers who are nursing their babies, and patients who are pregnant. So we actually advocated on that front, and they disregarded everything we said. They actually said, fine, we won't switch nursing mothers or pregnant patients, but once they're done, they will be switched. And for pediatric patients, they just said to us that they had evidence that they were going to go ahead and switch. So when we ask for what evidence they have, they keep talking about the European experience, and I think that might be something maybe Dr. Moietti or Dr. Armstrong can talk about, but we need to be able to take a look and say, why are governments making these decisions when looking at the European experience when we are Canadian patients, and what they should be doing is looking at the evidence that our physicians have posed and the exemptions that the physicians have said should be taken into account here, and that is pediatric patients, nursing mothers, and women who are pregnant.
I definitely have something to add to that. It kind of goes with this lady's testament too. So she was diagnosed when she was 7, and like she said, some biologics don't work, and sometimes your disease can outlast the longevity of the medication you're taking. She's got her whole life ahead of her. So why are we switching her without her doctor's information and consideration? We were told by the pharmacist at the company that makes her Remicade that we were just told by a pharmacist. There was no formal letter, and her doctors actually didn't know about the switch. So.
Yeah, that's what non-medical switching means. As a doctor, this is very frustrating for me in general, but particularly in this instance. So you may tell from my accent, I'm not from, and in fact, I'm not, neither is David, from Canada originally, although we're both Canadian now. I'm from the UK, so is David, so at least for now, part of Europe. What Mina is really saying is governments have made that decision and the earth hasn't ended. That's basically it. And of course that's true. You really have to have a very dramatic difference for you to be able to see it in everyday clinical practice. That's why we demand randomized trials. The Americans, as I say, were killing more people than were dying in the Vietnam War, but they didn't notice it. Because, they was treating people with heart disease die. People on biologics do lose response, even when they stay on the originator drug. But what the randomized trials show is that you lose response more often, about 33% more in the biosimilar case. Now, that, when we have hundreds of patients, actually is difficult to detect. So all they're really saying is things seem to be okay. But the reality is they are not okay according to the evidence. And again, they could have seen this if they had prospectively looked in all their patients they were switching and compared those who actually stayed on the originator. The only country to do this is France, so congratulations, France. But everyone else hasn't. And that, by the way, was not for non-medical switching. That was for just starting the biosimilar rather than the original. So my plea is to governments is you need to look at what you're doing and not just say it's fine.
Well said. Next question.
Hello, my name is Dimitri. I'm from northern BC, so I am in the same, I have Crohn's disease. I've had it for 10 years. I've been on Remicade for just shy of 10 years. It's been working. And so I'm going to be affected by the switch. I have one question which is asking for a statistic off the cuff, so I recognize that that's probably, hard. But I also thought when you're saying glisten and glitter, I was thinking as a way of sending a message, we could use monopoly money to represent the amount of money that they're saving by switching us all from the biologics, because it is a similar currency to Canadian currency. That would probably, I wouldn't mind paying my taxes with monopoly money as well to the BC government. Nevertheless, my question is, as I'm on Remicade and I've been so stably for 10 years, I will be most likely forced to switch over to a biologic. What is the statistics on the body's ability to create antibodies after switching? Is there a statistic saying so many percentage of people that, because my fear is I go to this new biologic, I don't get a response. Remicade has been working, but if I go, can I go back or will I have an antibody develop? What's the chances of that? Thank you.
Also a concern of mine.
So there is no randomized trial that answers that question in non-medical switching. That first trial I talked about, 220 patients with Crohn's disease, they actually, for simplicity's sake, I didn't do the design, but the design is exactly as you said. At 30 weeks, actually, those that were on the biosimilar switched to the originator, those on the originator switched to the biosimilar. There was no difference in antibody levels in that trial. So that is reassuring, but it is actually only a small number of people. We'd actually need more evidence to know it's the same. And whilst antibodies are important, they're not the be-all and end-all. The biggest detriment to discovery is the illusion of knowledge. And we think antibodies are important, but to be honest, in an evidence-based way, we do not know. And even if they are important, they're clearly not the only thing. So that's why we focused on these clinical outcomes. That's what we can really be confident in. For the little evidence we have, antibodies aren't increased in the biosimilar case.
Do you have anything further to add, Dr. Armstrong?
I think I would reiterate what Paul said, which is that the biggest barrier to learning things is the illusion of knowledge. And the problem is we don't know that the antibodies that we measure actually play any role in the loss of efficacy or continuing efficacy. And we don't know that there aren't other antibodies or other processes that may lead to problems as well. So the most important outcome, and the one that Paul alluded to, is that the switch does lead to a loss of response in patients who've been stable on infliximab, and that's what we have to deal with. What the mechanism is really almost the sort of icing on the cake, and we probably don't understand it very well.
Actually, I just want to add, because the previous speaker did talk about saving money and monopoly money. There is one trial, it's Turkish, so not directly relevant to the Canadian setting, but actually those switched to the biosimilar cost more money to the government than those that stayed on the original drug. Now what we focused on inflammatory bowel disease, that was everyone, including rheumatoid arthritis. So may not be directly relevant, but the little evidence we have suggests they may not save the money they think.
I think that's a really important thing, and we talk in funding about silo budgeting. And so this is designed to save costs around the costs of medication. What it doesn't talk to are the other direct and indirect costs that come with flares. We're trying to investigate flares, to switching to different biologicals, because the recommendation is not to switch back to the originator infliximab, but then one's looking at alternative biologics, which then may or may not work and may be significantly more expensive than the originator, biological originator infliximab. And as we heard also, there have been discussions between the companies around the originator companies reducing the cost. And that's one of the things that we talk about in the position statement, is that the assumptions we make around cost effectiveness are based on imperfect or incomplete data about what the actual costs are to the healthcare system. So one gets the feeling that this is a decision based on a limited assessment of the costs to the system, and then it's being pushed through without appropriate mechanisms to monitor what else can occur as a result of these switches.
And I'll just add to that when we spoke to the BC government, we asked them, are you going to be monitoring those patients that you're switching? And the simple answer was no.
Next question.
So my name is Usha Chauhan. I'm a nurse practitioner at McMaster Medical Center. I have a question for Shana and her mom. And the question is, you found out from the pharmacist that the next infusion, or maybe 2 or 3 infusions, are going to be switched. Has any healthcare provider spoken to you? Do you have access to your physician to discuss this? Do you have access to your nurse or a nurse practitioner to discuss this? Has that process been set up for you?
Well, what happened was we got this phone call, and immediately I was like, that's not right. We're not going to do that. So I phoned her team. She has a whole team of doctors. We actually still see her original GI specialist in Edmonton. And in short, her nurses were like, that's not going to happen. I'll get back to you. I have some phone calls to make. Mm-hmm. And so we haven't discussed this. They don't want this to be the option for her. It's not what's best for her.
Because talking to some nurses, one nurse in BC, my understanding was that special appointments were being made, or extra appointments were being made. You can spend time with your nurse as well as your physician to discuss the switch and your options that are available. And I also was told that if you don't want to switch, you can make that request too. I don't know if that'll be granted or not, but that, it can be made.
Well, I think that's kind of what her doctors were doing, is just kind of trying to rally for the fact that we don't want to make the switch. It's not what's best for her. So, yeah, they have kind of gone forward to help, but the reality of the situation is we had literally just been to Alberta for her 6-month checkup, and a week later, after being home, was when we got the phone call, and the pharmacist was actually like, why didn't your doctors talk to you about this? And it's because they didn't know.
So the other last comment, psychological impact all of this. I mean, is that something that's been expressed from your point of view?
Well, yeah, in my speech there, I did express that, having a sick child is fairly traumatic. It consumes my life, really. And so having to make these extremely heavy decisions that could potentially impact her future heavily it's quite stressful and scary.
Thank you. Next question.
Hi, good morning. Thank you all. My name is Martin. I'm from the London chapter. So my question is more along the lines of clinical trials and evidence. From my experience, there's been a lot of discussion around choosing the proper outcomes for a clinical trial, and things like the patient voice are now becoming more important. But that leads to this idea about medical switching. Is anyone sort of incorporating things like patient-reported outcomes into the decision around medical switching, or is there an initiative that could maybe move to bring that into the body of evidence?
So this alludes to what I was saying before, is no, the trials use patient-reported outcome. They also use biological things like inflammatory markers in your stool or your blood, but certainly symptoms were one of the key indicators for them. So in the trials, we can be confident that symptoms in one case stay similar, in the case of just starting a biosimilar from nothing, but in the case of switching, they're worse. So yeah, that answers that, I think. That's what you're getting at.
I mean, in fact, sort of non-medical switching is really mandated by payers, and there are surveys looking at the impact of that. They're tough to design, but studies from the States suggest that, as we heard before, there's a significant burden on the healthcare providers in terms of writing letters to third-party payers to try and advocate for their patients. And we heard also from BC that they actually have no plan to monitor anything in terms of outcome, if I understand correctly. So that's not even standard outcomes of whether or not there's a disease flare or a switch. And they're certainly not going down the road of asking patients whether they feel stressed or upset. So this looks like it's a policy change with no intent to ascertain whether or not it's had any impact other than that potentially on budget. And it's not clear that we'll ever learn whether or not there was an improvement or a savings from a budgetary point of view either.
Thank you.
Thanks.
Yep. I'm just going to sneak one question in right before here. Question is, if governments are quick to, or if governments have done Remicade, the Remicade switch, how quick will they be to do the next one?
Well, you can't predict, but one would imagine they would do it almost instantaneously next time. But that's just my opinion. I mean, you don't know until you. But I think the other thing to talk about is this non-medical switching. How is it brought about? So, of course, you have to incentivize people, and what happens is that the pharmacist will get reimbursed, in inverted commas, for switching you. So they will get paid just for switching a person. Doctors, by the way, never get paid directly anyway for starting a biologic. That is just not allowed. But I would emphasize, of course, doctors are biased too. There are certain clinicians who are heavily involved with the pharmaceutical industry and doing many talks, which they're paid for. And of course, they can be non-evidence-based as well. And I've certainly seen that and probably will in the meeting I'm about to go to. So it's not just criticizing pharmacists or governments. Doctors also have biases related to incentivization, but none of this is good for the patient. And the other thing I would emphasize is that all the people who were involved in this position statement were chosen because they don't have conflict of interest. It's been over 2 years since I've done a talk for a drug company, and I don't. David also has no direct conflicts with biosimilars.
And that was the entire panel, Eric Benchamal and others, and Gregorios Leonotadis as well.
Very important. Sorry, go ahead, please.
Hello. Is it on? Hello? Hello?
Yep.
Hello, Ryan from Saskatoon. It's quite common, and we've heard here today, that people are willing to travel great distances for good health care and in some cases even move to a different province. My question is, assuming that this forced switch doesn't become Canada-wide, would you predict that a large number of patients would move away from provinces that have a forced switch? And if so, how would that influence a provincial government's decision to enact a forced switch?
Well, that's a very interesting question. I would think that it would be very difficult for people to move provinces, move their jobs, move their families. I don't know, I know that Shayna and Denise, you've moved to BC just for that reason.
We moved for support of family, and upon receiving the information of this, we immediately said worst case scenario, and we're moving back to Alberta.
Yeah. And the issue is that she could move back to Alberta, and the Alberta switch is happening this week. And we believe very strongly, and this is what I said to you earlier, is that patients need to speak up, because what's happening is BC said, no patients reacted, it's all good, we're fine. So Alberta said, hey, no patients spoke up, we're good, we're going to implement it as well. And that's what the other governments in the other provinces are looking to say, if there's no noise, then we're good to switch.
Roar.
Next question.
Hi, my name's Aaliyah. I'm from Nanaimo. I have a couple questions from my chapter back home. One of our ladies has a 10-year-old daughter who has Down syndrome in addition to her IBD, so she's quite medically fragile. She's on Remicade, and she gets a calprotectin fecal test 3 to 4 times a year, covered by the company who makes Remicade. Who will be covering those tests when the switch is made? It's $160 each.
Yeah. So for the moment, the biosimilar will fund that.
Okay.
Pfizer is a drug company like any other who makes the infliximab biosimilar. So they will do that, but that comes at a cost too. The difference in cost is not huge. It's not as huge as it could be, and I think part of it is because the infrastructure in place, at least at the beginning, is similar to what you have for the originator. Okay. Of course, in time, one can predict it will get less.
For sure. What happens to those who, for some reason, don't tolerate the biosimilar?
So that will be up to the clinician. Yeah. But
is it up to the clinician, or is it up to the government?
At the moment, that even in BC, that's still up to the clinician. But what the clinician will probably do is switch to another drug, not give you infliximab again, because that's where the government will step in, and it's not worth the aggravation. So they will give you either a different anti-TNF alpha drug or a different biologic altogether.
Great, thank you.
Thank you. Now, I think that Dr. Boyetti has to depart at 12:30?
Well, I've got a few more minutes.
Excellent. Well, that's great.
Hi, Dr. Moyetti. Nice to see you again.
Yes.
My name is Chantel. I'm a volunteer with the Durham chapter. I'm also the host of Guts and Glory podcast. I'm on my second biologic. I just started Entyvio. So right now the threat of a biosimilar for Entyvio is not current or in Ontario. I just had a question about infliximab and Remicade and the pharmaceutical companies. The biosimilars are, my understanding is the reason why there is a biosimilar for Remicade is because the patent has ran out. correct?
Yes.
Okay, so for the new patent, I'm assuming the pharmaceutical company that makes Remicade, Janssen, doesn't own that patent. So with pharmaceutical money, are they helping our cause? Like, is Janssen pushing our cause as well? Like, we're forcing people to switch to biosimilars, which means they're not going to be taking Remicade anymore, because there's a lot of money there. So I feel like we got to get our voice and that money in the same room.
Yeah, no, Janssen have moved out of that market. Once a generic, just in terms of drugs in general, comes in, the company just moves away. And it's been the same with infliximab as well.
And by moving away, you sort of mean like they give up?
They just give up.
Great.
Unfortunately, that's the model that they've always used. In a sense, I don't mind that, because I'd be uncomfortable if it's the pharmaceutical industry pushing for their drug to be used. I'd rather the evidence and the patients be the ones doing the pushing.
So it really does leave us on our own for this fight.
Yes.
Okay.
Unfortunately, you are, although, as I said, I'm a little ambivalent about a pharmaceutical company. It's not that they're all evil either.
No.
But just to be very clear, there's very good people in pharma that save lots of lives. But there's also an interest to their shareholders, and the government would quite rightly look upon that skeptically.
Thank you.
Chantal, you're not alone, because we're doing this. We're here with you. Crohn's and Colitis Canada is here for you, and all of you here in the room and everybody else impacted by these diseases. That's why we're raising our voices today, and we're going to be launching something at the end of this session that's going to help governments listen to what we have to say.
Yeah, I'm with you, Mom and Shayna. By the way, Shayna, IBD warrior for sure, amazing. We need a shirt for you. But I'm on my second biologic because my first biologic, which I will leave unnamed, almost killed me. So I was in ICU. I was hospitalized for about 6 weeks because I had a reaction to it, very severe. So it took me almost 6 years to make the decision with my GI, Dr. Silverberg at Mount Sinai, to start Entyvio. This wasn't an easy decision. It was a hard decision. I'm still on my induction doses. I get my next one in a week. So the thought of just how long it took me to make the decision to say yes to this with 30 plus, I was hospitalized 30 plus times in the last 6 years because of my disease and refusing to go on a biologic. And then when I make that choice, the threat of that choice now being made for me it's terrifying. It really is. It's terrifying and it's infuriating at the exact same time.
I hear that.
Yeah.
That's very well said.
Sorry, can I just interject? Because I have to go now, I'm afraid. So sorry to the next two questions. I recognize someone at the back there, but anyway, the other plea that Chantal does a podcast, Guts and Glory. I was interviewed by her on fecal transplants. This is something that we are studying in Crohn's and ulcerative colitis. The belief is that this disease can be cured. That's what CCC want, and indeed have funded research by us in looking at fecal transplants to change the gut bacteria from a disease state to a healthy state is the idea, with some success. I wouldn't want to say it's a miracle in every case, but certainly some people seem to benefit. So this is something we're doing, but this is now part of a much wider thing, looking at how gut bacteria and diet can cause ulcerative colitis and Crohn's disease. So this is happening across Canada, and we're wanting to for you to fill out a questionnaire, give a stool sample, a urine and blood sample. Basically, that will allow us to look at the gut bacteria and look at your diet and see what that is like compared to people who are healthy. And we hope through these sorts of work to actually get towards a cure for these diseases. So for those of you who aren't, Edmonton is involved in this, and indeed your pediatrician will now be involved in this. So if you please volunteer wherever you are in Canada, that would be wonderful. And I would like to thank CCC, who've been very generous in supporting this initiative, as well as our research body, Canadian Institute for Health Research. So thank you for allowing me to be part of this this day. It's really important. Your voices must be heard, and I wish you every success in making that happen. Thank you.
Thank you.
I just want to say thank you to Paul, Dr. Moietti. He's been an incredible partner for us. Thank you very much for coming and speaking, and we'll be able to share some of the things that he just talked about in terms of volunteering for some of these studies that he's doing. But we just want to thank him because he and his team stepped together, because when the government said we didn't have evidence, they stepped up and gave evidence. So thank you very much to Dr. Paul Moietti.
Thank you.
Great. We have time for a few more questions.
So I just wanted to speak to pediatrics as well, because I have a 16-year-old son who's on Remicade. He has been for 5 years. He's doing awesome and has been only on Remicade, so has not, like, he's been successful on the first biologic that he was on. It's my understanding, like, we're protected by Children's Hospital right now. I'm from Victoria.
Right.
So we're in BC. We know there will be a force switch in our future, but we've been told by the head of GI, Dr. Jacobson is his actual doctor, he's the head, and he said that he's advocating as much as he can to keep children that are already on Remicade for as long as possible. I know that adults have to switch in BC in March. So I'm just, we feel protected a little bit. For now, he said he has no idea how long that will be, because Oscar will be pushed out of Children's when he turns 18. So we're hoping that it'll last for another 2 years for him, but I'm wondering if you think there's any chance, because BC already has this force switch in place, if we keep fighting and saying, no, this isn't a good idea, do you think there's any way there will be a reversal?
Let's
in
hope
this
so.
force switch?
So one, let me start by saying that we've worked with Dr. Kevin Jacobson, and he has voiced his opinion, which is that he doesn't want pediatric patients to be switched in the province of BC. Again, the governments have not heeded this advice from the gastroenterologists who are treating their patients. And we tried very hard as Crohn's and Colitis Canada to have these discussions with the BC government to say that please, have the exemption for pediatric patients. I know Dr. Jacobson is working on that, but I've been told very clearly that pediatric patients will be switched in the province of BC. It's not just for adults. So that is going to happen before your son turns 18. One of the things is that I believe very strongly that what we're launching today, and I was going to announce this at the end, but I'm going to announce it now, is that we started a letter writing campaign in 2015, which was incredible. We had thousands of patients who wrote letters to their MPs, and that actually delayed the switch policy. So what they were going to do is in 2015 switch, and they didn't do it until 2019. Our voices are important, and I believe very strongly that if we write letters to our MPs and our MPPs and tell them that we don't want this switch, I believe in my heart that we could see a reversal or at least a delay again to look at the evidence before a switch is made. So I think your voice is really important in this dialogue.
Absolutely. So you were told that they're advocating to prevent the switch for your son?
Well, basically, yeah,
okay.
For as long as possible.
We were told the same thing. Her specialists and doctors are advocating and fighting to prevent this switch for her. But we were told by the pharmacy that February will be her last funded dose.
And I think that one of the things that we heard from the physicians is that what the BC government said is that every GI can write an exemption. So that means that what Dr. Jacobson is doing is writing an exemption for you and saying that your child should not be switched. But GIs eventually, they have only 24 hours in a day. If they have to write exemptions for every single patient and then to get a notice back from the BC government, that could take months and months and months. And by that time, they will have switched you.
I know they're starting, all the children being diagnosed now, they're starting them on the biosimilar.
Mm-hmm.
Right, they have to.
Yeah, and that's one of the other issues that we talked about with the paper that was released. And Dr. you can, David, if you can just talk about that, Dr. Armstrong.
So as Paul Moetti said, there are basically two scenarios, and the initial scenario is for patients who've not had biologicals or not had infliximab before. Actually, the evidence does not show, at least the limited evidence we have for Crohn's disease, does not show that the biosimilar is inferior to Remicade, to the originator infliximab, and therefore, as a start-off, it's reasonable, and the position statement is that it's reasonable to start with the biosimilar. That's a very different question from switching somebody who is stable on Remicade, on the originator, to the biosimilar, where the data seem to suggest that there is significant risk of increased relapse or worsening of disease. And governments conflated those two. They make assumptions from the treatment in people who've never had it before, and without evidence then extrapolate that to the switch, and that's what they're doing at the moment. So I think, again, it's making sure that the arguments that we put to government are appropriate, and it's finding ways to get around what is effectively, I think, is, it's a campaign, it's a strategy that they've used in other areas, which is just to keep on motoring through and hope that there isn't enough pushback to make them change course. From I'm not a great politician, but from what I can see, government is never going to admit that they'll think about it. They'll make a sudden policy change when something forces them to make a change. They're not going to go, well, we'll think about it a bit more, because that's basically indicating a degree of weakness. Having said that, there are other areas where, if there is sufficient noise, MPs don't like to be embarrassed by people in their area who are doing badly. They do not like their pictures. They don't like pictures of cute kids or suffering because of a change. And it's often that breach point, I think, which will make the difference. And there are areas, in completely different areas in Ontario, for example. It's interesting, wireless capsule endoscopy, which is a little pill you can swallow to take pictures inside the gut. Government didn't pay for that. They didn't pay for it. And at some point, a relative of somebody who was in politics found that her mother was having to pay for the capsule, and she raised stink, at which point government went, oh, we reviewed the policy, completely independently of the complaints, but we've reviewed it and we've decided that this is an important investigation that needs to be funded under limited circumstances. So it's the opportunity, it's making a noise, it's looking for the opportunities to make the changes where it can be achieved.
And I think when we just earlier talked about starting bio-naive patients on biosimilars, the paper is clear that if there's no cost differential, so the paper that we're alluding to is between CAG and CCC, is that if there's no cost differential, they're suggesting that the patient be started on the originator drug. So I think it's really important for many of you in the audience to review at least the executive summary of that paper. That paper also suggests that they don't recommend a non-medical switch, and they also don't recommend an automatic substitution of your drug by pharmacists or others. So we can make that available to all of you in terms of the 3 top recommendations that have come out of that paper.
Hi, my name is Karen, and I'm the DC in Newfoundland. I also have Crohn's disease, and what I'm hearing from a lot of people in Newfoundland is we can't even get in to see the doctors, and when we do see our GIs, now that they're so overworked and there's a shortage of them, we're ushered in and out so quick. So I was just, when you were talking about having the conversations to figure out what is actually a flare and what's not, how do we fit all that in to make sure we're getting our voice heard by our GIs to make sure? I'm on my 2nd biologic now. But, when you're in and it's quickly look at your thing, type your tummy, and we need you out because I have the next patient coming in. Just what's the language that we can make sure we use to the GIs to, ensure that they're on our side or, in such a short period of time? I know they're overworked, but you feel sort of like, okay, get in, get out next. So that's what we're hearing a lot from in Newfoundland. So just how do we put that in quicker to make sure they know we don't want to be switched?
So that's a really tough question. I raised it almost as a sort of aspirational goal. I think a key part of it is when I talked about that, I summarized some of the key areas where there are other things which are not necessarily IBD that can play a role in symptoms, and being aware of that means it's easier then to communicate with the physicians. I think part of this is then working with physicians, with organizations like Crohn's Colitis to try and work out or develop as educational or informational packages which allow and facilitate the communication between busy physicians and patients, so that the key points of information, the key monitoring areas come to the fore and can be summarized effectively. And that applies not just in IBD, it applies in a lot of other areas as well. It's a big undertaking, and I do not for an instance minimize the challenges both from the physician side but particularly from the patient side.
Karen, one of the things I will say to you is that GIs tell us all the time that they wish they could spend more time with their patients, but they have so many patients, and that talks to our increasing incidence of patients that are growing in Canada. We're going to be at 400,000 patients by 2030, and the number of GIs is not keeping up with that. And when you think about the nurses, we only have 80 part-time IBD nurses across Canada. So that's something Crohn's and Colitis Canada is doing, is trying to advocate for more nurses, and we're actually also, we've started a telemedicine program in Ontario that is done very well, and hopefully we'll be able to expand that program across Canada, and that's all based on all of you helping us to raise the funds that we need to be able to implement those kinds of programs.
Go ahead. Hi, I'm Carol, and I'm from York Region, just north of here. My question may be a little bit more of a conspiracy theory than this. Sorry about that. But I'm listening to all this, and we've got the government involved, and we're not happy with that. But there's insurance companies that underlie all that, and I think there's sort of a pull there. So I guess the question I have is, because the fear is I'm not on a biologic and I'm not on a biosimilar, but we know that insurance companies love to switch out to generic medication. And even if we can convince the government not to do this, how do we get insurance companies not to do that to us? Because we know they're going to run with it. And they're going to run with it once they hear that there are provinces that are running with it.
Yeah. So I will say to you that we've also been advocating on your behalf with the private payers. And what the private payers are doing is that they're actually waiting to see what the governments are doing. One company in particular that I will mention, because they're very vocal about it, is Green Shield. They will only reimburse you for biosimilars and only fund biosimilars. And so we're talking to so many different companies around what they should be looking at in terms of evidence. So we advocate on your behalf with them, but we know that they're waiting to see what governments will do. And the minute governments decide across Canada that they are going to implement the switch policy, they will too. And I have actually I introduced Durhan here before, and she's actually just went to a private payer event a couple of days ago, so maybe you have some insight on this as well, Durhan.
First of all, thank you so very much for doing this, because, and I'm so sorry that Dr. Moriarty is not here. Just to say in context, you folks do not maybe fully appreciate what an amazing organization you have, because Mina's taken this on, your physicians have taken this on, and the challenge for you, quite frankly, is that the two biggest groups that are affected, that is rheumatoid arthritis and diabetes, have caved. Their organizations are not standing up for them. Their physicians are not coming out and saying the same things here. So you folks are in an incredible, incredible position because you've got that kind of support. That being said, you can also appreciate the fact that if they've got these huge patient populations that are already switching, you've got a big road to toe, because they do not want to, number one, have to have an exception that's going to try to rock their boat. And we know that. We come from rare diseases. We're forever that little tail that's trying to whip that dog. So you guys are in that position. You're like the tail that's going to try to whip that dog. But I think you can do it. And I hear what Mina's saying. The private players, unfortunately, are listening. But I think what they're not listening to is the other fact, and that is the originator companies have stepped up and said, okay, we'd rather have a small share of the market. We'd rather have a lower profit on this than have nothing. So they've come forth. Now what we've got is payers, private payers, as well as governments are saying, we don't want to talk to you. We won't listen to you. because we want to, quote, create a market for biosimilars. I mean, that's the most dangerous thing I can believe. Why do you have to create a market for biosimilars? We believe biosimilars could have a place, the originators could have a place. You compete. They keep telling us in Europe, I just came back from the European Payers meeting in Berlin, very clear. Europeans are not switching whole scale to the biosimilars. In fact, in some countries, it doesn't exist at all. You heard Dr. Marietta talk about Turkey. There's no biosimilars, for instance, in Belgium. They do not, they couldn't compete. And what the Europeans are saying to us is very clear. The best pricing comes when you've got competition, not when you've got a monopoly. So it is important for us to continue to do this. What you folks are doing is absolutely phenomenal in terms of pushing that message. And I mean, again, from little disease groups that have continuously been whipping that dog and getting it to move. We think that there's a huge opportunity here, but we also think that what you're doing is so important for everybody. It's not just for the IBD community. So, take the time, stand up, make your voice heard. I mean, Mina is one of my heroes in terms of what's happening here. No, really, we cannot get the big groups to move with us. They are quite willing to basically say, we don't want to rock the government, we don't want to rock the drug companies. They will tell you privately, we believe this, we support this. We don't believe that we should be allowing governments to make that. But then you got them to stand up to say something about it, and they won't do it. So this is a tragedy. And you get patients who are kind of being steamrolled and basically saying, well, I don't want to do it, but they don't know how to stand up to it because they haven't got the kind of support that you've got here. So you've got an incredible opportunity. And certainly, I think for all of the patient community, the message that you're putting out is that patients and clinicians need to be able to make the choice that's best for their patient, and it's not up to governments to actually do that. And I think also, to echo what Mina's saying, the politicians are not really aware of what the bureaucrats are doing. This is coming at a bureaucratic level. And we've got to now get to the politicians and say to them, do you realize what's happening? It's like what Dr. Armstrong said. Once a politician got the message that, oh my gosh, this is not happening, that's where the action starts. So we need to actually activate your voice to the politicians, get them aware that this isn't something that their bureaucrats are doing. I know we talked to some of the politicians, they have no idea what's happening. So we need to get them involved. So I don't want to go on, but I just want to say, you folks are an incredible community. You've got an incredible organization. You've got incredible physicians. Really, really applaud what you guys are doing, and just continue to do it.
That seems like a wonderful place to stop. It's well said. Oh, one last comment here.
I can speak to the back of the room, so I don't need the mic. You're recording it? Give me the mic. Thank you. It sounds like pharmaceutical companies have their own GR efforts, and the disease associations are left on their own to do their GR efforts. And what you need to be doing is lobbying government for this. So my question is, have you reached out to other sister diseases, other autoimmune-based diseases, to see if they can combine their efforts with you? I know GR is an expensive endeavor, but it sounds like you are very well organized. You have the resources, at least in terms of evidence and physician support. Could that concerted effort be combined with other associations to really place some heavy lobbying at the various levels of government that need it, federally and within the provincial jurisdictions?
Absolutely. So we, Crohn's and Colitis Canada, belong to something called the Biosimilars Working Group, the Better Pharmacare Coalition, the Best Medicines Coalition, and we all have these conversations, and we try to bring groups together. As Durhan said, that there are some groups willing to work together, and Durhan and I have been working together. There are some other groups that are really trying to help on this basis. I think everybody wants to do some good work. Some are saying that this is sort of a done deal, we're going to move on and not really push for it. And there are other groups that are really vocal and working together. So there are absolutely a lot of people and groups that we're talking to and working with and collaborating with and partnering with for sure.
Great. Thank you very much. I guess that is it for this session. It's been fabulous, a fabulous conversation. Thank you to everybody. I'd just like to invite Mina to make some closing remarks.
So first, I want to thank Janet for facilitating this session, and I also want to thank our panelists, Dr. Paul Moietti, who you've heard from and who's left, Dr. David Armstrong, Denise and Shayna. Thank you so much for coming here from BC and sharing your story and talking about how this is impacting you as it's going to impact many of you also in the room. Thank you for being here. Thank you for listening. But again, we have to have a call to action. That call to action is to write, we're starting a letter writing campaign today. And I'm wondering if we're going to have it on screen. Maybe I can just tell you what it is, but we'll have it for you here. It's action.crohnsandcolitis.ca/choice. It will allow you to talk about your patient-doctor choice. Write a letter, and it's very easy. If you go on there, it really shows you what you need to do. That automatically sends a letter to your MP and MPP. We need them to have these letters. What I've been told by government is if one letter lands on their desk, they'll look at it. 2 letters, it's a fire. It's an emergency. So if your MP receives 2 letters from patients, they will consider that something that they need to look at themselves. So join us in making your voice heard. I want to thank you all for being here, and we have a lot of staff and a lot of board of directors and everyone else here that can help and talk to you if you want some more information. Thank you all.